With your host, Andrew Donaldson. This is Heard Tell.
Welcome back to Heard Tell. I'm Andrew Donaldson. This is going to be good. We're going to talk a little healthcare. Another of our great Young Voices contributors, Elise Amez-Droz. I didn't say the Z's. I practiced hard on it. Great writer. She's been writing about healthcare stuff. Ma'am, how are you? Thank you so much for the time today.
I'm doing great. It's great to be here.
It is. I appreciate your time very much. Let's start big picture before we delve into some of the writing you've been doing. I want to do a little perspective because we seem to have some really well-worn narratives in American media, especially the news media, especially social media, about our healthcare system. Give us a little bit of perspective, though, because, you know, if you listen to Twitter, people are dying in the streets and it's horrible and it's the worst healthcare system ever. And or there's people who's like, yay, the free market is the best thing ever. We know neither of those is true. You've spent a lot of time overseas. You spent time in America. What would you say the actual state of our healthcare system is? Because it's kind of been, and you wrote about this, it's been pretty static since the ACA, Obamacare, whatever you want to call it. Not a lot has changed. So what's the current status of our healthcare system if you take an objective viewpoint of it?
Yeah, objectively, we spend a lot of money on healthcare in the US. The government does and the private sector does. So I think the biggest lie that people believe is that this is a free market. Healthcare is by no means a free market. There are about $1 and $2 in healthcare that comes from the public sector. So we're really not in a free market system. Now, there is more market involvement here perhaps than in the rest of the world in many places, but that doesn't mean that the private sector here is unimpeded either. There are lots of healthcare regulations. And I think those two things together, the fact that there's a lot of regulations and still a lot of control from the public sector, that actually drives up our prices. So we spend more. That is very true. We spend more money per capita on healthcare than any country in the world. But that's not the full story. It's not because of the free market. There is so much more going on. And part of it is just that the government has done such a great job getting involved in every single aspect of our healthcare system.
And that's really the two-edged sword when we're talking about healthcare in America right now, isn't it? Is that there's all this money involved, but there's also all these strings about where the money goes. And then when you go to the private sector side, there really is some really definitive funnels of where all the money goes and where the money is to be made, just to be frank about it. How unique is that to the world, though? And I know people talk about things like socialized medicine or single payer or European style or whatever you want to talk about. How unique in the world is our system of healthcare where we have both of those and we have this absolute river of money going through it? And we have generally pretty good healthcare, but the problem is we're not really getting the bang for the buck for it, are we?
No, that's absolutely correct. To go back in history a little bit, in the 40s, we started having wage controls due to the war. And that's when employers started offering healthcare. That's a pretty unique thing in the world. There are very few countries where employers offer health benefits to employees. And that came about because they couldn't raise the wages, so they just offered new benefits. After the war, we solidified this, so we codified it in the law. The IRS says employers are exempt from taxation whenever they provide, that money that they give of the wages to their employees for health benefits does not go taxed. But past that, in the 60s, we realized, wait, not everyone's an employee. Some people cannot work because they have disabilities, and some people are too old to work. They're retirees. And so what do we do for those people? And that's when Medicaid and Medicare came into the picture. And we started, involving the government much more in our healthcare system. And so over time, that actually has led to a huge number of people being covered by Medicaid and Medicare. And while our quality remains very high, you mentioned earlier, people are not dying left and right. We have excellent care in the United States, despite all of the criticism that can be validly, expressed. But we've seen just how much this intrusion of the government and then the way we regulate what counts as, coverage, what counts as, good care, that actually has led to an increase in prices.
You mentioned the history of it going back to the 40s. It seems to me, because I tend to put history on a lot of the things I deal with, even if it's an economic or a political or a healthcare issue like this is, and this is all three of those wrapped into one. The post-World War II era really shaped America as it is now. That's where we got the explosion in population, we got the explosion in economic growth, and that's when the healthcare system became, well, we have all this competition for jobs, so all these jobs started offering healthcare benefits because they were competing for all these people and for all this economic growth. Well, we're 60, 70 years down the road from there. Does that model still work in America? Because that's the model as it's set up. The government's doing a lot of patching of the holes between that, but is the base assumption of, well, the employers are going to provide health care? That's really where the debate is on all this, isn't it?
It is, and there are several issues now. Like you said, over time, the situation has devolved into something that's not really sustainable. On the one hand, because healthcare costs have grown so much, we have a hard time providing health insurance to people at an affordable rate. So employers spend, $7,000, $8,000, $9,000, $10,000 per person for insurance, and that's a really high cost. Like whenever you want to bring on a new employee, you bear that cost that the employee may or may not see, because not every employee pays the premiums, and most employees do not pay the full premiums. So that's a challenge for small businesses that want to come online. How can they afford that? Like adding this burden for each employee that they bring on. And then for Medicare, when it was first created, people, like, life expectancy was around 69 years old. So people would be covered by Medicare for a few years and then they'd pass away. Currently, thanks to advances in medicine, we have much longer lives. And so people, someone who retires today has a life expectancy well into the 80s, which means that we're now giving people care for, 15 years, 20 years. That's very expensive, and it's not sustainable at the rate that we're seeing it now.
Yeah, Medicare and Medicaid is always going to be an issue. Let's come up to the present moment, though. The dominant force in the healthcare debate and discussion and discourse has been the Affordable Care Act, Obamacare. We're 12 years down the road on it. We know what was promised. We know some of the jingoistic stuff, like, like your doctor, you can keep it. We know that part of it. But it's been static. Nothing's really changed demonstrably from that, despite Republicans saying they were going to repeal and replace it, which we always knew was a little bit of a song and dance, which now we have the evidence they was. 12 years on, what did it do? What didn't it do? Because that's really the framework we need to take as far as going to, okay, what's our next steps in trying to improve healthcare here, isn't it?
Yeah, so one thing that it promised, or at least Obama on the campaign trail in 2008 promised that he was going to cut costs for a family of four by $2,500 a year. Well, our costs have tripled or quadrupled since this happened. So since we passed Obamacare. So costs have not gone down. It has not been affordable. Has it covered everyone? Because we were saying, we're going to protect patients, we're going to give them coverage, but we'll still have roughly 30 million people who are uninsured. That's about 1 in 10 Americans. Now, some of them don't want to be insured. There are reasons why the Obamacare design, went away at first. Everyone was supposed to have insurance or they would pay a penalty. That penalty went away. But still, it's not closed the coverage gap, you could say. What we have seen is lots of people benefiting from the Medicaid expansion. So many states expanded Medicaid coverage to people who were not previously eligible, people who didn't have disabilities or didn't have an income below the federal poverty level. And that's been the main way through which people have gained coverage through the ACA. Now, that coverage is not great, and it is also pricey both to the federal government and to the states without seeing great improvements in health outcomes.
Yeah, talking to Elise Amez-Droz, Young Voices contributor who works in healthcare related issues. I got to point out this too, because part of the reason it's been static, that doesn't mean we're not doing things on the edges of it. In fact, the 2021 stimulus bill, the American Rescue Plan, you just mentioned COVID. Part of the COVID stimulus was they dumped a ton of money for subsidies for folks to get onto the ACA care plans. Obviously, there's a health pandemic, there's a health issue, so that makes a little bit of sense. But if we go back again, that was exactly what this was supposed to avoid, and here we are doing the money into it. Was this a gap in the policy? Was this a gap in how it was written? Or was this just one of the unintended consequences of the way the ACA was written to start with?
So those benefits, these subsidies are supposed to go to people who aren't quite eligible for Medicaid because they earn too much, but or are not, don't meet the criteria, but also don't have employer-sponsored insurance. Now, during the pandemic, the logic was people are losing their jobs, right? So we have to find a way to give them healthcare coverage. If they have COVID, they'll need to have coverage. However, the coverage that we gave them isn't great at all. So the most affordable plans on the ACA exchanges have a deductible of $7,000, which means that when you have that kind of insurance, you need to first spend $7,000 out of pocket on your care before insurance kicks in. Most people don't have that money sitting around anywhere, especially if they're the kinds of people that you'd expect, to struggle to find healthcare coverage because they're not employed. So that kind of coverage is, in my view, a dishonest form of giving, insurance to people, because it makes them feel like they have access to services and that they will be covered. They only realize after the fact that a lot of it was not covered, or maybe all of it wasn't covered. So that was the logic, is giving people insurance, but then we didn't really account for the true cost of that insurance. And actually, it happens that a lot of the subsidies too went to people who could very well afford private coverage out of pocket. So during the pandemic, those subsidies were very generous, and they went to people who absolutely did not need them.
Yeah, and you wrote about it when you wrote a national review on this, and we're going to link to your article. We encourage people to read it. The problem with subsidies when it comes to healthcare, as opposed to something like farming subsidies or whatever other subsidies you want to point to, is what they've been doing with this, especially in things like the American Rescue Plan. They're really hiding how high the cost is with the subsidies. And that's where you get into where you're saying, look, this isn't fair to the people, because you're talking about $7,000 out of pocket. We see all the data of, like, if a normal family would have to come up with $500 cash, like 3/4 of them couldn't do it. You're talking about $7,000. That's a lot of money to a lot of people. These subsidies are hiding some real glaring gaps in this system of healthcare that we currently have, both the government side and the private sector insurance side, isn't it?
Absolutely. And that's the way healthcare is interesting. Like, health insurance is an odd way of paying for care, because most of healthcare spending goes to chronic disease. About 70% of healthcare spending is for chronic disease. And the key characteristic of a chronic disease is that it is chronic. It doesn't go away, right? So when you have a chronic disease, you have to, you'll need the drug this month, next year. Like, that doesn't really change. And so when we pay for it with insurance, if you think about all kinds of insurance that we have on the market for other things like home insurance or life insurance, they protect against things that may or may not happen. Like, if you have life insurance, it's in case you pass away, right? So we're hoping and banking on the fact that you won't, but just in case you do, here's money that will go to your family. In the case of health insurance, you can predictably measure how much you're going to spend in any given year if you have a chronic disease, because you know how much your drugs cost, you know how much your doctor is, how often you need to see them. And so when we use health insurance the way we currently do, we spend a lot of money up front on something that we know we'll use. And I think the system itself is a bad way of paying for care when it's so predictable.
Yeah, talking to Elise Amez-Droz. We're going to take a quick break on Heard Tell. When we come back, we're going to have a grown folk talk about healthcare. We're going to get past the buzzwords, government-funded healthcare, private sector healthcare. We're going to get into what we're going to do, because this hybrid model we got has made a big old mess. More with Elise Amez-Droz right after this. Welcome back to Heard Tell. We're continuing to talk little healthcare today with our friend Elise Amez-Droz from Young Voices. She's been overseas on her undergrad. She went to Duke for her master's. Very smart lady. Like I told you before, I'm a huge fan of Duke's hospital system because I was a patient of it for a very long time. When I talk healthcare, let's turn the buzzwords off, because we talk about single payer and free markets. Let's just have an adult grown folk talk for a second. When we talk about healthcare, I always tell people two things. I was like, look, I've lived in Europe. I've been in European hospitals. I've seen the taxes they pay, and I see the healthcare they get. I'm also a VA patient. So I know the largest integrated healthcare system in America, and we need all that money in the third largest department of government to take care of 9 million people. The numbers on this stuff don't match up. What are we going to actually do to try to improve this? Because this hybrid insurance, private sector, government, everybody agrees that it's got a lot of limitations and the problems are only going to get worse. You argue in your piece that one of this would be to empower the individuals where they don't have to go through an employer and they don't have to go through the government at all. Why do you feel like that would be a good middle ground to try to break through some of the hybrid mess gridlock that we've got going on right now?
I think Americans want to be empowered to make their own choices. This is a different mindset than in other countries around the world and even in Europe, where people might be more comfortable, like you said, with higher taxes and then just letting the government take care of things. I think we have a distinct mentality here about how we go about taking care of ourselves. And the employer-sponsored model gets in the way of that, because if I have insurance through my employer, I'm stuck there. And I need to find insurance elsewhere through another job. If that's, if I want to change jobs, I will lose my current coverage. Actually, it's possible to take the coverage with you and you're going to be spending $15,000 to $20,000 to do that, like while you're finding, looking for a new job perhaps. So it's completely unaffordable. What we should have is a way of having these benefits be portable. So if you have insurance, you can take it anywhere with you. It doesn't depend on your job. The reason why we have employer-sponsored insurance right now is, like I said earlier, there's an employer tax exemption on spending on health insurance. And so that exemption should be applied to people, not to companies, because that would actually allow for this flexibility. And one word about international models. We can look all we want to other countries. We can say, oh, if only we had a system like the British system, or like Singapore, which is a system I personally kind of like. This is just not how it's done. We can't just overnight uproot everything we have here and switch to a different model, even if that's what we wanted. We have a system that is the way it is. And so we are bound to make changes that will go towards something better, but we can't just overnight change everything. So we have to be realistic. At the end of the day, what is it that we can do? And I think those kinds of changes can actually be really meaningful. If we make those benefits portable, if we give people agency over their healthcare dollars, then we start getting somewhere that is both aligned with our values and also financially responsible.
Right. And you work in the healthcare field, you do consulting on this. The other side of that, of course, is the only way you're going to guarantee that portability is the government's going to have some kind of a hand in it. How would you see legislation going where you have a government powerful enough to protect people from their employers, from the Medicare, Medicaid system itself in some cases, because the states have different rules? How do you have a government that has that much power, but is also still going to be able to give some individuality and some freedom to these folks to get things like those tax benefits? Because we've already seen it with things like ACA. Our legislative branch loves these big sweeping regulations. They love big sweeping bills. They're just going to say, well, why don't we just cut out the middleman and we'll just control the whole thing? That would be the concern with that, is that they'll go for the one and you wind up with the other. How do you think that could work legislatively if you could get it done?
Well, I think we've done it in some regards already when it comes to Medicare. So Medicare used to be just a pure administrative top-down system, right? So Medicare would say, I'm going to reimburse doctors for every single service that they provide to a Medicare beneficiary. And that's still the case for many beneficiaries. But now, since fairly recently, people can switch to what's called Medicare Advantage. So instead of taking what the government offers them, they'll find a private plan that gives them coverage that's usually much more generous than what the government gives. And then the federal government reimburses those plans a flat fee a year to take care of those patients. So it can actually be done. This has led to more competition because there are many providers, many health insurers that offer Medicare Advantage plans. It's given flexibility and more agency to patients on it. So I think there are ways in that regard that work. And like you said, for to change the portability, I think it's simply changing, Congress, if that is what they want to do to reform the portability, they could change the rules around the employer exemption. I think it can be done.
Yeah. Talking to Elise Amez-Droz, our friend from Young Voices, healthcare expert, as you can tell from having listened to her for the last 18 minutes. Let's talk about that for a second, though, because Medicare expansion is wildly popular. Every time it goes on the ballot, it almost always passes, even in deep red states. Do you see some way? You just mentioned it's already been retooled some from the original bureaucratic system that it started out as. Is one of the paths forward just going to have to involve Medicare expansion because it's so popular? It's not going to get pared down. No politician's ever going to touch that. There's going to have to be some element of that somehow. Is it going to be scalable enough to solve 30% of this problem, 50% of this problem? Where do you see that going? Because obviously that's the direction the people are going. The politicians are going to follow them. Where's that leading when it comes to this healthcare discussion, do you think?
That's a good question. So I was talking about Medicare Advantage, which is for seniors. The Medicaid expansion is for people who are low income or people who have disabilities. So for those people, like you said, there is the expansion. So states are moving to extend Medicaid benefits to more people than were originally on it before the ACA, before Obamacare. You're right, it's a very popular policy at the state level. Now, states are finding out that it's a lot more costly than they expected. The federal government reimburses states for the money that they spend on Medicaid beneficiaries, but as it's turning out, it's been a lot less affordable for states than they expected. So I think this is one reason for which some states are not going to adopt or going to delay adoption of the expansion for a while. But my view for Medicaid is actually it should become much more efficient. There's a lot of bloat in it, a lot of ways in which Medicaid beneficiaries are not taken care of very well. And Medicaid should be for people who are truly in need, truly indigent, cannot work, cannot take care of their family without Medicaid being available. But for everyone else, what we want is incentives for people to get off Medicaid, because private insurance works better. It's much better to be on a private plan than it is to be on Medicaid, because you're kind of at the mercy of the state, which is never a good thing. So I think the types of reforms there are different, but program integrity, just more transparency in Medicaid would go a long way.
Yep. And here we are right back to talking about cost again, which, every time you talk about healthcare, we come back to the cost. No matter which way you talk about it, more government, less government, more private, less private. How big of a piece of all this, if we're going to have any kind of a coherent, consistent system of healthcare in America, goes to they've got to figure out some way to have transparent pricing and level pricing across the healthcare system, because that's really where all the holes, where all the good intentions fall into, isn't it? Because there's just nobody knows what they're paying until after they get charged. Then they spend years fighting it. Insurance don't cover it. It does cover it. This is really the maelstrom that's driving all the churn in the healthcare system right now, is that I don't even know what term you want to use, the lack of transparency in the billing. I know the regulation makes it that way in a lot of cases. It's not all the hospitals' fault, but the hospitals are perfectly happy to cash the checks at the same time. Talk about that for folks that maybe don't fully understand it, or who have never had, like I've gotten, where I've got 5-6-year-old medical bills still showing up. Talk about why that's such an important piece, because all this other stuff doesn't work if they don't straighten that part of it out. Because it's just like being in debt. If you never get out of debt, you never fix anything anyway, right?
Exactly. The problem with the lack of transparency is that we don't ever buy anything else without knowing how much it's going to cost. You can't make a decision without knowing how much something's going to cost. Like if someone says, do you want to spend, a week at the Ritz on the beach? That sounds great. Oh, how much is it? Oh, wait, I can't afford it. Like you will make a decision when you have all the facts, and it's not just enough to know that it's going to be good quality. So in the same way for healthcare, people can't make meaningful decisions. And when you can't make a meaningful decision, you're not really in charge of the care that you get. You're not really in charge of your course of action. And it also makes you less responsible, because if someone knows that they can get, if there's a financial incentive for you to stay healthy, you will also, want to take care of yourself, want to improve your health status. So for all these reasons, transparency is very important. I don't think we can have cost savings, but I don't think we can have also better quality of care without people knowing how much things are going to cost ahead of time and then making a fully informed decision.
Yeah, talking to our friend Elise Amez-Droz about healthcare. All right, let's do some nomenclature real quick to kind of put a bow on this. When folks are talking about healthcare on their social media or just in their conversation, I think the buzzwords have absolutely destroyed this conversation in a productive way. people go immediately to socialized medicine, or they start talking about, single payer if they really want to sound like they know what they're talking about, even though they probably don't. What's some better terminology that people should be throwing out there that will drive discussion, as opposed to just when you say socialized medicine, that wall goes up immediately? What's some terminology people need to talk about? You already mentioned transparency and pricing. That's a good one. But give folks a couple things that they can talk about, even the folks that are maybe on a different ideological side than them, and they can kind of start changing their language in these conversations and see if we can get them a little more productive.
Yeah, so one would be patient empowerment or patient choice. Just, the determination that you make for your own care. And another one that I said earlier, maybe a bit wonky or not as fun, but portability, just having access to something that's portable that you can take with you. And then, just options, more options, like healthcare options. I think we as soon as we go into a universal healthcare kind of system, as soon as we go for socialized medicine, we lose those options. And I think people value them a lot more than they realize. And it's only when they go away that people start missing them and realizing how much they were valuing them prior to them going away.
Yeah. To put a bow on this and bring it back to the beginning of what your article is all about, we've had kind of this status quo since about the ACA or Obamacare went into effect. It's been about 12 years. You pointed out in your piece that's good in a lot of ways because things haven't gotten overly measurably worse at the same time. But we also understand time stops for nobody. How long can this go in this current state before we start seeing real problems? Because we're seeing some strain on the system just from the fact that, inertia moves us forward, but there hasn't been any new regulation. How long can this go before there's going to need to be a real serious overhaul just out of necessity? Because I know a lot of people, the accusation during ACA from the Republican side was, well, they're building this to fail to collapse the system, or 12 years down the road. That hasn't quite happened yet. But at the same time, this can't go on forever. Give us a little bit of a time frame and give us some of the things to watch for of like, okay, we need to get in here and do some remodeling one way or the other.
Year is 2026. In 2026, a big chunk of Medicare, the part that pays for hospital services, is going to be bankrupt. So we won't have a choice at that point. Congress will have to act to change things. And then the other parts of Medicare too are even worse. So sooner or later, for Medicare beneficiaries, at least people who are 65 and over, they will have to see their benefits decrease. So something that used to be covered won't be covered anymore, or they will get fewer, drugs covered and things like that. We'll feel that this decade. So there's no time to lose. There's a lot of reforms that should happen sooner than that, so that the shock is less violent when it happens.
All right. I asked you and you gave me the specific date, 2026. Of course, it's a midterm election year. They probably did that by accident, I'm sure. Elise Amez-Droz, outstanding information on healthcare stuff. This situation ain't going to go. You just said it. We've got a ticking time bomb that we're going to deal with this one way or the other. I'm sure they're going to wait till the last minute. Until we get you back on to talk about this some more, let folks know where they can follow you, where you're writing, your social media and all that, until we see you again on Heard Tell again.
Yes, I'm actually pretty offline. I don't have a Twitter, but I do have LinkedIn. So you can find me there, Elise, Elise, and then Amez-Droz, AMEZ-DROZ. And you can just follow me on LinkedIn. I have a creator profile that you can easily follow.
Fantastic. She's also on the Young Voices page. You can find her there. They have all kinds of stuff, including some clips of her doing things. And this clip will be up there. Elise, thank you so much for the insight. Really appreciate it. Hope to have you back soon. Thank you so much for the time.
Thank you, Andrew.
Appreciate it.